So Bruce, is engagement of patients in their own care, is that an issue?
It's an issue and it's hugely important because we find that even when patients are referred to a pulmonary rehabilitation program, very frequently they just don't go, or they'll go and go for 2 or 3 sessions and stop. And so there are some major barriers we have to think about as to why patients don't persist, and then think about strategies to improve adherence to pulmonary rehabilitation or exercise.
So there's a lot of different barriers to patients participating in their own care. They fall to a couple different kinds of conceptual areas. What are those concepts?
Well, there's the avoidance of breathlessness that feels uncomfortable to do this, especially if they haven't been exercising. And then they start and they go and they find that it makes them very uncomfortable. They're not motivated to go back. Then there's all sorts of other barriers, psychological distress, and even sometimes little barriers that you might not think are important.
So there are a lot of patient barriers to patients doing health-enhancing behaviors. There's also physician barriers. What do we not do, Rich? We need to do a better job at engage our patients and motivate them.
Well, to be honest about it, I don't think that most physicians have the training that we need to do these things. This is a highly sophisticated thing you need to do to motivate patients. I often say that rehabilitation people, they're no good unless they're motivators. They get people to do what they don't want to do, what they find hard to do. That's what their job is.
First of all, I agree with you. I think that there are physician barriers, partly because physicians may not have been trained to do it, and then there's always that issue of time. I don't have the time to do this. I've got to go to my next patient. If I start talking at length with the patient, I'll be here 45 minutes. And a good example of a communication tool is shared decision making. We hear a lot about shared decision making. It's on the tip of everybody's tongue. It gets discussed a lot. But let's spend a minute talking about it. Shared decision making really has components. The first one is taking the time to engage, of talking to your patient, understanding what's important to them. What are they concerned about? What are they worried about? And that leads to the second component, which is goal setting. So making sure that we've discovered a goal that will motivate the patient. The goal can't come from the physician. It has to be a patient-centered goal, and it reaches down emotionally to what's really important to that patient.
So Bruce, we did a very interesting study, I think, and you were a primary author and motivator of the study in terms of looking at motivational enhancement to get people to do the things they want, and then we gave them the ways to achieve those activities by doing more steps. Can you tell us about that?
Yes, this was a study of about 120 patients with COPD. They were randomized. Half of them were in the goal-setting intervention group. The goal starts with having patients be able to walk more, so we had them wear a pedometer. But the key of this was goal setting. And so we had a very skilled health coach who met once with the patients for 30 to 45 minutes and worked with them to establish a goal, and then called them 5 times over 12 weeks. Short calls, 15 minutes, checking in on how are you coming on reaching your goal, and just giving support and encouragement. The patients in that goal-setting group walked 36% more steps in 12 weeks than patients who also met with the health coach, but who didn't do any goal setting. So goal setting is a really useful tool.
I often think behavioral changes, that doesn't sound very good, but lifestyle change. You're going to, to do this, you need to think about changing everything you do and scheduling your exercise, your activity to make sure that you do it. Is that helpful, Bruce?
Yeah, and that's part of that bigger discussion. There are some words that are off-putting to patients and some words that they respond better to, and lifestyle is a great one. People like to talk about lifestyle.
You know, Barry, it's interesting to reflect on where we've come from. It wasn't all that long ago that our advice to patients with COPD is, if you get short of breath, stop doing it. That was the clear advice until maybe the 1950s or 1960s. It's only more recently that we've really understood the importance of keeping people active.